40-year-old women, otherwise healthy lady, presented with heavy menstrual bleeding. So she is not menopaused. So she is having heavy menstrual bleeding. On investigation, she was found to have an endometrial hyperplasia without atypia. So this is, you know that there are two types of hyperplasia: endometrial hyperplasia with atypia, and the other one is without atypia. So without atypia, as you know, it has a lower risk of malignant transformation and it will spontaneously resolve. But they have mentioned that BMI is 32. So obesity is a risk factor for developing endometrial hyperplasia as well as carcinoma. So this obesity might have led to this endometrial hyperplasia without atypia. So you might think as it spontaneously resolved, we don't have to treat. But as she is symptomatic, having heavy menstrual bleeding, we have to treat it because to improve her quality of life. Otherwise, she is healthy. Most appropriate management. So the important management step in endometrial hyperplasia without atypia, if you list it down, that is risk factor management. That is number one. So obesity. If she is having obesity, that should be weight reduction is a must. And if she is on polycystic ovarian syndrome, also weight reduction is a must. And the other thing is hypertension, diabetes, that should be optimized. Control should be optimized. Those are the risk factor management. Then you have to treat the heavy menstrual bleeding. So you have different options. Progesterone is the treatment option. So you can go for Mirena, levonorgestrel IUCD, or else you can go for oral progesterone preparation. So the oral progesterone preparation are noethisterone and medroxyprogesterone. You should give it continuously, not you don't give the placebo pills. You have to continuously give it for 6 months. Oral progesterone pills, right? Then you have to follow up with repeated biopsy at 6 months and 12 months interval. You do the repeat biopsy and 6 months and 12 months interval. If you, with the biopsy, it means you usually do a PPL biopsy most of the time. So in the biopsy, if the histology report, biopsy report come as it has resolved, you directly discharge the patient from the follow-up. Think that at any time after 12 months, if the endometrial hyperplasia without atypia persists, or if the endometrial hyperplasia without atypia converted into endometrial hyperplasia with atypia or endometrial carcinoma, or if the patient has a poor compliance to medical treatment, or patient lost to follow up, if she is not ready to follow up, you will be going with TH, BSO, total abdominal hysterectomy and BSO. That is a final option. But the main option is risk factor management and progesterone-based contraceptives can be given. Ideally, the levonorgestrel IUCD is the best one. If she is not ready to take for levonorgestrel IUCD, you can prescribe her on continuous progesterone pills such as noethisterone or medroxyprogesterone for 6 months. So that is the complete treatment option you have to know. So here in this question, so what is the most appropriate management? Better is to give a levonorgestrel IUCD because she is that is the first option rather than going for noethisterone. In addition to this controlling of heavy menstrual bleeding, levonorgestrel IUCD itself will protect her from developing endometrial carcinoma in the future. Levonorgestrel IUCD, it will symptomatically improve the heavy menstrual bleeding. With that, it has an additional benefit where it will reduce the risk of developing endometrial carcinoma. So answer B.